Hello, my name is Patricia Dean, and I will be speaking with you today about the use of ketamine for the treatment of depression. As noted on the title slide, I have selected the topic of utilizing ketamine for the treatment of depression. Although this treatment is still in its infancy, research has shown considerable promise for using ketamine to alleviate treatment-resistant depression and suicidal ideation. My interest in the topic stems from my work in clinical practice treating patients that consistently struggle with symptoms of depression. I have seen that medication can lose its efficacy over time, and further, even when treatment is undertaken, a large number of patients with depression still continue to experience symptoms. Consequently, I believe that it is important to consider what else can be done to help those struggling with this mood disorder. This presentation includes an overview of the pathophysiology of depression, the pharmacology of ketamine, and how ketamine treats depression, and what advanced practice nurses should know when recommending this treatment to patients. The objectives of this presentation are included here on this slide. By the end of this presentation, the viewer should understand the pathophysiology of depression, identify basic pharmacological properties of ketamine, and recognize circumstances in which it may be beneficial to utilize ketamine for the treatment of a patient. To begin this presentation, I wanted to start with a brief review of the pathophysiology of depression. This information should be helpful for enhancing understanding of how ketamine works to treat this condition. A cursory overview of the literature on the pathophysiology of depression does indicate that there have been several theories that have served as the basis for understanding the disease. Although each of the theories does provide insight into the disease, scholars do argue that the pathophysiology of the disease is complex, making it difficult to acquire a complete understanding of how each theory fits together. Despite the fact that the picture of pathophysiology is not complete, a review of the two learning theories that have been postulated to understand the development of the disease is provided on the following slides. The primary theory regarding the pathophysiology of depression is the monoamine hypothesis. Under this hypothesis, a deficit in the concentration of specific neurochemicals, norepinephrine, dopamine, and serotonin, is the underlying cause of depression. Reduction in the levels of monoamines in synapses of the brains result in a decline of these critical neurochemicals, leading to the onset of depression. This theory of the pathophysiology of depression has served as the basis for the development of specific medications to regulate neurochemicals in the brain. Monoamine oxidase inhibitors, MAOIs, selective serotonin reuptake inhibitors, SSRIs, serotonin norepinephrine reuptake inhibitors, SNRIs, and tricyclic antidepressants, TCAs, all work to increase monoamine levels in the synapse as a means for regulating and stabilizing the levels of critical neurochemicals, norepinephrine, dopamine, and serotonin, that regulate mood. While the monoamine hypothesis of depression continues to serve as the foundation for understanding the pathophysiology of depression, advances in research have provided additional insight into how this condition develops. In particular, neuroendocrine dysregulation via the hypothalamic pituitary adrenal (HPA) system has also been implicated in disease development. Stress activates the HPA, and in individuals who experience chronic levels of stress, it is hypothesized that increased glucocorticoid secretion occurs. Increases of these chemicals have been associated with a wide range of deleterious health outcomes for the patient. In addition to increasing levels of depression, excess glucocorticoid secretion is associated with changes in the immune system, as well as promoting increases in inflammatory markers. These changes alter signaling pathways in the brain, a process that can change feedback loops, inducing immunosuppression and the onset of a wide range of interrelated diseases, including depression, diabetes, and heart disease. When this data is collectively reviewed, it becomes evident that the true pathophysiology of depression has not been fully elucidated. Even though the pathophysiology of depression remains somewhat of an enigma, there is evidence which does provide insight regarding how the disease develops. Understanding the role of the HPA system in the evolution of depression is clearly an important objective for research. Even though the monoamine hypothesis of depression is useful for understanding depression from the standpoint of what occurs in the brain, study of the HPA system and its role in the development of depression appears to provide a more systemic understanding of how this disease develops and impacts the body. With a basic review of the pathophysiology of depression provided, it is now possible to provide an overview of ketamine. As you can see, ketamine is a synthetic, non-barbiturate, injectable, dissociative anesthetic that is often preferred drug of choice for short-term surgical procedures in adults and children. Ketamine produces a dissociative state in which the individual feels separated from his or her body and the environment. For anesthetic purposes, ketamine is often viewed as having some advantages in terms of preserving airway reflexes, spontaneous respiration, and cardiovascular stability. Ketamine results in the inhibition of the thalamocortical pathways and stimulation of the limbic regions of the brain. This unique combination enables the patient to maintain neuronal connections required for consciousness while experiencing complete detachment from surgical pain. More specifically, ketamine is a non-competitive antagonist of the ionotropic receptors of N-methyl D-aspartate, NMDA, which reduces calcium ion influx, preventing the neuronal activation needed for total consciousness. The pharmacological profile of the medication is provided on this slide. Information regarding the medication indicates that ketamine is metabolized by CYP450 in the liver and is excreted in the urine and feces. The medication has a half-life of 2.5 hours and can be administered orally, intravenously, or intramuscularly. Time of onset following an IV bolus administration of 2 milligrams per kilogram of ketamine. The time to onset is 30 to 60 seconds, with the effects lasting between 10 and 15 minutes. Because the medication is primarily metabolized in the liver, patients with hepatic dysfunction may be more likely to experience the effects of the medication for a prolonged period of time. Emergence syndrome may occur for patients following medication administration. Emergent syndrome can include hallucinations and out-of-body experiences that can last for up to 3 hours following administration of the medication. Although ketamine continues to be used as an anesthetic, emerging research on the medication does indicate that it can be effective for the treatment of depression, including depression that does not respond to other medications. Unfortunately, the exact mechanism of how ketamine works to treat depression is not known. However, studies conducted to evaluate the mechanism of action for ketamine in the treatment of depression do indicate that ketamine simultaneously binds to different receptors in the brain, which produces a cascade of effects that work in concert. More specifically, research indicates that there are at least 3 receptors that are impacted by ketamine, including opioid receptors, NMDA receptors, and AMPA receptors. A review of how each receptor is impacted by ketamine is provided here. Opioid receptors are believed to be the first group of receptors activated in the brain. Ketamine is known to be an opioid receptor agonist and activates receptors in the brain to alleviate pain and increase euphoria. Following this immediate effect, researchers believe that NMDA receptors are activated by ketamine. Ketamine is known to be an NMDA receptor antagonist and blocks glutamate, the primary excitatory neurotransmitter found in the brain. After this occurs, AMPA receptors are activated by a metabolic of ketamine, hydroxynorketamine. When this occurs, glutamate neurotransmission is further blocked, leading to a significant antidepressant effect. The juxtaposition of current research regarding the mechanism of action for ketamine in the treatment of depression suggests that there are notable differences between what is known about the pathophysiology of depression and how ketamine works to reduce depression. The differences have promoted some scholars to argue that a glutamate theory of depression is needed to fully understand depression and its treatment. Although the monoamine and HPA theories of depression have provided important insight into depression and its treatment, What is being demonstrated through the use of ketamine for the treatment of depression is that there are other mechanisms that may control the development of this condition, making it imperative to reconsider how depression develops and what would be effective for treatment. Studies investigating ketamine for the treatment of depression are still in their infancy. However, the success of ketamine for reducing depressive symptoms and ameliorating suicidal ideation have prompted the American Psychiatric Association to establish clinical guidelines for the use of ketamine in the treatment of depression. Ketamine should only be utilized after other medication trials have been unsuccessful. Ketamine for the treatment of depression is typically provided through an IV infusion and can be utilized as monotherapy or in conjunction with other antidepressant medications. The optimal method for administering ketamine for the treatment of depression has not been established, nor has the optimal dose needed to foster symptom abatement. Patients receiving ketamine may need more than one infusion of the drug. However, many often see dramatic improvements in symptoms after one treatment. Dosing should not exceed 200 milligrams per liter during treatment, with dosage calculated based on patient weight. In most instances, patients should experience some therapeutic effect from the drug within 2 weeks of administration. Subsequent infusions, if needed, must be based on patient response to the medication. Ketamine has been shown to have a good safety profile, with most side effects resolving spontaneously. Common transient side effects of ketamine include anxiety, blurred vision, dizziness, headache, and nausea and vomiting. Long-term side effects from the medication can include abuse or addiction, neurotoxicity, bladder toxicity, and hepatotoxicity. Supplemental materials for learning more about the treatment of depression using ketamine are included on this slide. Journal articles reviewing the topic are included, along with YouTube videos on the topic from the Cleveland Clinic and the Mayo Clinic. These resources should provide you with more information regarding this topic. To foster further discussion of the topic, I have included a discussion question on this subject on this slide. Specifically, I'm curious if a patient presented to your practice with a history of treatment-resistant depression, would you discuss the use of ketamine for the patient? If yes, why? If no, why not? Give 3 reasons to support your decision. Ketamine for the treatment of depression is a novel approach to care that is still in its infancy. While ketamine shows notable promise for treating depression, what is known about the pharmacology of the medication clearly challenges current theories about the development of depression. While depression is known to be a challenging and enigmatic disease, further research to understand the pharmacology of ketamine and its use in the treatment of depression may provide more than just a viable treatment option. Research in this area may lead to new insights into how depression develops, as well as new medications and interventions to treat the disease. From this standpoint, what has been learned regarding the use of ketamine for the treatment of depression is highlighted as truly remarkable.